Welcome, everybody. My name's Carl Costanzi from Western Maine Health. I will be your moderator today for the medical screenings and community response session of the MPHA conference. Just a reminder that there is a survey for you to take on the side of your screen to be able to get CME credits. Today we have with us Steve DiGiovanni. He will be talking about a systems approach to addressing ACEs in primary care. Then we have Andrea Richards and Laura Vinal talking about connecting patients to nutritious food through community partnerships. And then we'll have Clay Graybeal talking about approaches to screening for substance use disorder. And disclosure, there are nothing to disclose. And here are our session objectives. And just to let you know, we'll be taking questions at the end of the presentation, but you can enter your questions anytime during the presentation. And our panelists will be happy to answer them at the end, assuming we have enough time. So we're going to begin with Steve. Steve, take it away.
Hey, good afternoon. Excited to be able to present. This will be a pretty rapid fire kind of overview of our Maine Health approach. The mission has been to prevent, identify, and treat adverse childhood experiences. And so we'll go to the next slide. So traditionally, the medical community really has almost always intervened at the top of the kind of public health pyramid around that disease, disability, social problems. And so a big part of our work is to come in at the two lowest kind of big population health levels to really try to prevent adversity. And if there is adversity, addressing it early and trying to prevent the longer term impacts on social, emotional functioning, on health, on academic outcomes, work outcomes, and relationships. So that's kind of how we've been approaching this project. Next slide. So the key really is that for adversity is part of the human experience. And so yes, we would like to try to prevent it, but just as important or more important is we can build resilience. We can build it from a prenatal point of view. And actually early childhood, 0 to 3, is the time in which you really can build immense amounts reserves of resilience within the brain and body of the individuals. And the majority of that happens through connections, experiences, and attachment. And so the bottom little picture there is showing the fulcrum can be shifted. So even though this individual might have had more red adversity, it can be outweighed by the positive childhood experiences by building up the resiliency. So that's like kind of shifting that fulcrum down. And so just remembering for all of us, for individuals, families, and communities, we can build resilience each and every day. You probably have to click a few to get through this. Yep. So really taking the 2-generation approach and understanding in every visit in the pediatric, when we're going to see pediatric patients, that the well-being of the parents is crucial to the well-being of the child. And so making sure that we are supporting that dyad with all of our interventions. And also at the same time, that when the children thrive, it really helps the parents thrive when they're doing well in school and in childcare that's supportive and making progress, or their medical needs are taken care of. So just coming at it from both sides and really taking a whole family approach. Next. We have a lot more information on how to do a trauma-informed approach. We use the R's, so realize how common it is and that it has a significant impact. Recognize the symptomology, signs, and use screening tools in a trauma-informed manner, and to make sure that we truly respond in a way that is supportive and respectful to avoid re-traumatization. And then remembering every day, every encounter, are we actively building resilience? Next slide. When we teach a trauma-informed manner, we use SAMHSA's guiding principles. So for each interaction, whether it's with staff, leadership, patients, are we creating a safe environment? Are we being trustworthy and transparent? Are we using choice, collaboration, mutual respect? Are we connecting individuals to peer support, whether in the workplace or within the own community? And are we starting to address some cultural, historical, and gender issues? Next. For each of our major steps forward for our project, we have a very specific framework that we always look at, because we're trying to do these interventions across a pretty large health system. So we make sure our education is in place and ready to go. We do it in an integrated model, so no provider or team feels they're on an island. So we use a lot of behavioral health integration and partnership with the community. I'm pretty excited about the food insecurity teams presenting after us. Making sure that our tools and workflows are efficient enough to accomplish this in primary care and are aligned with the way the offices are set up and the way our EMR is set up. And then we use a lot of data to kind of help support the practices, kind of highlight to leadership what we've accomplished, and to evaluate the project. Next. I'm not going to go through all of our specific screening tools. The top sentence to me kind of really sums it up well. So what we're trying to do is look at currently, has there been recent trauma, recent financial stressors such as food insecurity or housing insecurity? Are there current post-traumatic symptomology from either previous adversity or recent adversity? And then what's the cumulative level of adversity this child has faced? So really looking at what's going on right now in the context of a cumulative picture. Next. Our toolkit is available to check out. Each year, right around October, we update it, and we've just started to post our newest version. You can see the website down below. If you just type in Maine Health ACEs, it'll bring you also to the web page. It has the workflows, and my favorite part of it, it has language. So we partner with our behavioral health experts. How do you address these issues in a way that is respectful, collaborative, uses choice to really help families make positive change? Next. The workflows are really very consistent for all of our tools, and probably the most important thing to take from this slide is it's the entire team. So we always train the entire team. We try to make sure they understand each part has a very, very important role. We use some pre-visit planning to make sure that the screeners are used and responded to. We really emphasize intra-team communication to make sure that we're responding to any positive screens. And then we try to really support the team and the provider that there are resources available. There are next steps that we can do. Next slide.
Code Gray R6 IMC, Code Gray R6 IMC, Code Gray R6 IMC.
Yep, in the hospital. So this is one of the examples of one of our screening tools. Uses some trauma-informed language to introduce it. We screen here for food insecurity, diaper insecurity, and then at the bottom is our 2-question trauma screener that looks at, has anyone hurt or frightened you or your child, or has anything bad, sad, or scary happened? If either of those questions are positive, we use a PTSD symptomology screener on the back. Next. The screener gets much longer for adolescents, so we do those same types of screenings, but we also look at a PHQ for depression, CRAFT for substance abuse, and then we use the de-identified ACEs number screen. So these are very difficult questions. We're not asking, don't tell us exactly which ones it was, but give us the number. That helps, we really find helps families and or teens be able to express difficult things that have happened, and gives them the choice if they really want to dive in or talk about it. Next. This is probably one of the key things that changed my practice of really making sure that we're checking in. Is there symptomology? It doesn't mean that they specifically have a diagnosis of PTSD, but it does mean there are things we can do to prevent them from having long-term symptomology and getting in early with some very effective validated behavioral health treatments. Next. Quick learning that we found out is it works much better to hand these questionnaires out than to have them ask rapid fire during clinical check-in. And we had a 300% increase in our positivity rate when we did that. And that was pretty much every practice. When they switched over, it would jump about 300%. It didn't matter if it was inner city, rural, or suburban. Next. We've been working on this for a few years, probably 6 years total, but with rapid expansion across the whole system in the last 2.5 years. And so 42 practices across Maine Health are using some of our screeners. And it's pretty exciting to me because the numbers just explode. So 30,000 were screened for trauma with a positive rate of 8%, 17,000 screened for an ACEs number, and 9% or more had 3 or more. You can see our food insecurity rate there, 4.6%. Over 1,500 kids screened for PTSD symptoms, and the SWIC is our developmental screening tool. So an incredible amount of data and then response that we're trying to implement. Next. This is another way of looking at it. We screened in a high volume. We identified 2,539 potentially traumatic events. And of those, 780 identified significant post-traumatic symptomology. The key is within our system, we've been able to invest in integrated behavioral health clinicians, and then we double invested by providing them additional training to provide validated trauma treatments. And so we're able to do warm handoffs at any age, and we're scheduled before they leave the office to provide, it doesn't have to be long-term treatment, but rapid skills-built training that can bring down symptomology. Next. Our big focus in the upcoming year is the 0 to 3. I'm not going to go deeply into that, but it's the age at which you build your brain that you have the rest of your life. So we really want to focus on building individuals' brains to their best potential. And so we're doing a 2-generation approach to try to accomplish that. Next. This is our bumper sticker. If you want one, email me. I love seeing them around. But basically the concept is, can we help support our parents to be the one for their child, to provide a safe, stable, nurturing environment? And can we be the one for the child comes in to be fully excited to see the family there, to be supportive, to just exude that excitement, whether they're struggling or not, or have needs or thriving, just making sure that it's an inviting, supportive environment.
Thanks very much, Steve. That was great. So much important information there, and potential data for people to access in the screening results that you're getting. We're going to move on now to our next panelists, Andrea and Laura.
Great. Hello, everyone, and thank you again for joining us today. My name is Laura Vinal, and I am a program manager at Good Shepherd Food Bank. I'll let Andrea introduce herself.
Hi, I'm Andrea Richards, and I am a program manager at the Healthy Community Coalition.
So we're here today to talk about screening for food insecurity in clinical settings, and then leveraging community partnerships to connect food insecure patients to healthy food in their communities. We're going to start with a quick overview of Good Shepherd Food Bank and the Franklin Community Health Network. And then I'm going to speak about Good Shepherd's role as a statewide organization promoting food insecurity screenings. And Andrea is going to speak about how that looks in practice through the Franklin Community Health Network in the Farmington area. All right, so Good Shepherd Food Bank is the largest anti-hunger organization in the state of Maine. We are also the only Feeding America food bank in the state. We serve communities in all 16 counties. Our mission is to eliminate hunger by improving access to nutritious food. And we do that by partnering with over 500 community organizations to distribute food to folks locally. Those community organizations look like food pantries, meal sites, soup kitchens, schools, after-school centers, healthcare organizations, senior housing centers, etc. And what we do is we work with retailers across the state and across the country and local farmers to procure food that then goes out through our network of partners to distribute locally. Last year, we distributed a little over 30 million pounds of nutritious food to Maine communities, and we served about 180,000 Mainers. Next slide. So today I want to specifically talk about our healthcare partnership program called the Community Health and Hunger Program. And this helps address the connection between food insecurity and poor health by working with healthcare providers to adopt food insecurity screening tools and providing resources for patients that are experiencing food insecurity. What Good Shepherd does is we provide technical assistance to promote the food insecurity screening tools, such as the hunger vital signs, and training in food insecurity and best practices for screening patients. And then we provide information for healthcare staff to give to patients that do screen food as food insecure. Resources include information about the local food pantries that they can access and nutritious food that they can take home straight from their doctor's office. Next slide. Next slide, please. Thank you. So currently our Community Health and Hunger Program operates at 123 organizations across Maine and New Hampshire. We partner with primary care offices, hospitals, specialty care offices, harm reduction programs, behavioral health offices, etc. Since January 2020, our partners have distributed about 130,000 pounds of nutritious food to patients and provided 3,500 referrals to our community-based food pantries. And what we see is that an average of about 70% of food insecure patients are in immediate need of food at the point of care, meaning that when they screen food insecure, they don't have access to a local food pantry or are not eligible for programs like SNAP or WIC, and they need to take home straight food from their doctor's office. Annually, our partners are serving about 6,000 patients with nutritious food. These are some examples of the resources that Good Shepherd is able to provide to our healthcare partners. We have a website dedicated to the screening tools, best practices, national toolkits, information about the current food pantry network. We have food pantry guides for every county in the state of Maine that are updated every 6 months, as well as information about SNAP and WIC and the federal programs that folks may qualify for. Next slide, please. And then the one unique thing that Good Shepherd can bring to the table, quite literally, is food access for our healthcare partners. So we know that a lot of folks cannot get to the food pantries within their community for a number of reasons, whether that be transportation or their hours of operation or just stigma of going to the food pantry. So we want to make sure that our partners that are screening folks are able to address food insecurity right in their offices. So we provide shelf-stable grocery items that our healthcare partners can distribute at no cost to their patients, as well as fresh local produce. Most of our partners distribute food through a pre-packed emergency grocery bag that contains healthy items like all natural peanut butter, chicken, tuna, low sodium vegetables, shelf-stable milk, brown rice, etc. They also had the option to order supplemental items if they are dealing with a patient population that has specific dietary needs. And they have access to fresh local produce through a partnership with our Mainers Feeding Mainers program. And the next two slides are just kind of highlighting our partnerships throughout the state, especially in light of COVID. Our partnerships, our healthcare partners across the state have been working really hard to promote their programming during COVID, and then also working with local food pantries to open up distributions and support community-wide distribution. So going above and beyond just their patient population and really looking at how they can serve as a community access point. So you can go to the next slide. And then I think, Andrea, it's up to you.
All right, so I actually am a part of the Franklin Community Health Network, and we are part of the Maine Health System. So our network provides rural health care throughout Franklin County. And I've listed some of our network partners here, and the Healthy Community Coalition of Greater Franklin County is one of those networks, and that's who I work for. But we are closely connected with our hospital, Franklin Memorial Hospital, which is how I got involved with all this work. So next slide. So a little bit of the history of how this came about in our community is that we were looking a few years back to do some food insecurity screening, and we talked to the providers in our pediatric office, and they were very excited about what these screenings would bring for information. But the problem that we came across was that we didn't feel that we had a way to deal with positive screens. So they were hesitant about moving forward until we could kind of close that loop and have some sort of resource beyond just handing them, where the local food pantries were. So we said, all right, we'll go back to the drawing board and we'll see what we can do. So fast forward a year and a half later, Maine Health was looking at doing more screening, and we were working on a grant in our community that was able to connect people with resources. And then perfect timing, Good Shepherd Food Bank came in and said that they had a pilot program for us to that they wanted us to work with them on, where we could actually give out emergency food bags to people when they screened positive. So we went back to the providers, very excited that we were able to kind of have a resource and a way to actually help people in the community beyond just identifying that they were food insecure. So we go to the next slide. We were able to get the screening started in our pediatrics office. They have been our champion and a little bit of our poster child through this work. And we were able to set up a system to get them started with the screening. We had just started with our new database. So it was set up in there. We did a training. Thank you to Laura and the Maine Health team. They came up, they trained the staff, and we were able to figure out with Good Shepherd Food Bank and a local food pantry how we could get the food to the practice with, who would be working on what piece. So I was kind of that coordinating piece to get things going and pick up food and drop it off so that we could figure out what was the easiest way for us to do this and make it so it was easy for the practices to do it. Specifically knowing that the practices are really inundated with a lot of day-to-day work, and we wanted to not only have them on board, but make sure that it actually, was something that they could continue. Next slide. So it really takes a lot of collaboration to make this work. Luckily, we had Good Shepherd Food Bank, who, was able to provide us with some experience and some ideas of protocols and procedures. So I kind of sit in the middle in my role. So the Healthy Community Coalition, part of Maine Health. Like I said, I'm just trying to make sure the pizzas are all connected. The Pediatrics Office was the first office that we got on board, and they connected through Good Shepherd. Good Shepherd connected with us with the Care and Share Food Pantry. We have this wonderful pantry in Fairbanks, which is just outside of Farmington. It's pretty much Farmington. And they have been amazing to work with. So the food gets dropped off there, and then we go ahead and we pick up the food, and then we deliver to the pediatrics office. Since then, we've been able to expand into a couple other practices. So we're also working with our Farmington family practice, and they're located in the same vicinity, which is the back of the hospital. So I deliver food bags to them as well. And then we have our Livermore Falls family practice on board. They're the newest practice, and so we're happy to get them going with this as well. So next slide, I'm just going to share a little of the data. Pediatrics was really concerned in the beginning, which is why they were approached first about this pilot. They have a lot of young families, a lot of people that they could tell were struggling. So as you can see, our rates have stayed pretty high. We have some of the higher rates out of the practices that are screening. So we have about 8%. The last data that we have on here is in June, and it's stayed pretty steady around that rate since we started. And then they're screening at about 89%, usually a little bit higher. And I think, there's been some, through COVID happening, there's been a little bit of ups and downs, but one of the really great things during this time is that we knew that a lot more people were struggling, and not only were people seeing that, when they came in, they were being asked about food insecurity and knew they could get a bag then. They've called other times when they were needing food and they knew it was a place that they could access food, which is exactly what we were trying to create, a way for people to not feel like they did not have access to any food. So even though that may not be the norm, it's something that Pediatrics has been really excited that they have been able to offer, that people aren't afraid to come to them and we can help them with their basic needs. And then, so referrals and food access. So you can see the need, how the need for emergency food assistance typically rises and falls. It changes. You never really know, during what times. I think sometimes in the summer you start to see it rise again, and it might depend on what local school districts are offering for food. Luckily, right now, there's a lot going on, but we still know there's a lot of need. So I think a lot of communities are rallying around multiple avenues to really meet that current need. And we're lucky that we have this established in our practices. We have given over 8,000 pounds of healthy, grocery, nutritious food and fresh produce between May 2018. It seems like that was forever ago that we started. It's great that we've been doing it this long. And now October. There's been over 275 referrals that have been made to our local food pantries. We have multiple in this location. We've had some great resources that have been developed from this work that people can utilize, and that we've partnered with other organizations or other work such as SNAP Ed to make sure that we're giving out resources on how to even prepare food if families need it, especially if it's something they hadn't seen before. And we've had over 270 families served with these meals. So we're pretty excited about the impact that we've made and then moving forward. Right, so I don't know if Laura and I might kind of tag team the slide here, but we really started small. We started with one practice. We knew there was going to be a big need at this practice, but if you can kind of start with one and then start thinking about the bigger picture, we've created this huge resource at Pediatrics, especially. They've just, again, been this champion for us, that they wanted to do more. So even though it was something small, which really isn't small to be providing food, but they started with being able to provide food, but thinking bigger picture, they know the difference that it's making in the families that they're seeing, their lives. So we really also noted that we've got a lot of community members that need to support the work. So it would be easy to say, okay, Good Shepherd's going to connect with Pediatrics and they're going to work it all out. But there's a lot more to it than that. And especially where they're so busy, any way that we can connect, different groups of people to come together to support this work, I think it makes it work a lot better. And then, yeah. Go ahead, Laura.
I was going to say, I definitely finding allies in the community that can support work if you're looking at integrating any type of social determinant of health types of screening. It's been really great working with Andrea's team to look at what other resources are available for patients. So outside of the scope of addressing the immediate need for food, what else can we provide for patients, and who else in the community is serving the same population that we can tap into.
Yeah, and we're just looking forward to making sure that we keep the resources available and that we're making those connections wherever we can, and then keep identifying any gaps so that we can address those as well.
Great, thank you guys. That was awesome. And as Steve mentioned, that food insecurity screener is part of the ACEs screener. So if someone screens positive now, that through this community connection and collaboration, it can be addressed directly. Thanks very much. And Clay.
Yes, good afternoon, everybody. It's great to be here. Thanks for joining us. I'm going to talk a little bit about SBIRT, and I'll explain what that is in a minute if you don't know. At the University of New England, about 4 years ago, we received a federal SAMHSA grant to provide screening, brief intervention, and referral for treatment training to students, and we started out with 8 different disciplines, but we ended up, including students from 10 different programs, which made it the most diverse training in the country of any of the ESPERT training grants. And it was interesting because we included dentists, dental hygienists, occupational therapists, nurses, pharmacists, and so on. And the goal of ESPERT, obviously, is to make sure that everyone gets screened at some point for substance use. And that's what I'm going to talk about today. You can go to the next slide. We've covered the objectives, so you can go right on to the next one. So Steve had a pyramid, so I had to have a pyramid too. This is the drinkers pyramid. We're just going to focus primarily right now on alcohol. That's what this comes from. But it's a useful model, and it's also important to remember that despite the growth and use of other substances, that alcohol is still the most widely used and actually causes the most extensive health problems of any substance at this point in time. Part of why we look at this pyramid is to understand that a lot of people will say, well, how can I implement screening if I identify a problem? What am I going to do? We like to let people know that your first question is, do you drink or not, basically, and 40% of the adult population doesn't drink, so you're done in that screen. The next group is the low-risk drinkers, around 35% that are behaving in healthy ways. And it's interesting, there is a difference between men and women. Women can only consume up to about 1 drink a day. When it gets over that, the health risks increase. For men, it's actually a little more than that. It's up to 2 drinks a day. And that's, of course, that's general group data. It's not individual. So with folks in that low risk category, the goal is to simply reinforce their positive behavior and move on. It's really the top 2 groups that we're most interested in. About 20% of the general population are high risk drinkers. That doesn't necessarily mean they're dependent, but they may be having problems related to their intake. And this, you can see the parallel with other substances as well. And about 5% probably are dependent, somewhere in that neighborhood. And this is the general population. I know we did one presentation a couple of years ago where one of the providers looked at this and he said, well, my patient panel doesn't look like that. They're much healthier. So we had to talk about that. Next slide, please. So what is ESPERT? S stands for screening. The goal is universal screening for quickly assessing the use and severity of alcohol and other substances. The brief intervention is a brief motivational and awareness raising intervention. One of the things that we strongly believed in our program, and I've certainly seen throughout my career, is sometimes even a very brief encounter with a caring professional can make all the difference. Sometimes just saying, I'm concerned about you, can break through. And part of what we do is train all of our students in how to maximize the effect and impact. Let's say you only have a couple of minutes. How are you going to use that? And then the third part of this is the referral to treatment. So that's when someone's in trouble and clearly need help, to make sure that you're aware of and familiar with the resources, because that's the other question. What am I going to do if somebody really has a problem and I don't know how to deal with it? And so part of this model is about learning what the resources are. Next slide. This is what this model looks like. Our goal is to make sure that there's an annual brief screen for all patients or clients in one setting or another. It's often with your primary care provider, but it may be your dental hygienist. It may be your pharmacist. And there's no harm in a little repetition too, because there's also a level of trust and so on. And you can see the 4 outcomes there, little or no risk and so on, that we were just talking about. Okay, next slide. There are a wide range of standard screening tools that have demonstrated effectiveness. We focused in our training primarily on the audit for alcohol use and the DAST, which is the drug and alcohol screening test. There are so many different versions of these. We decided we didn't recommend any single one. The goal is to find something that will integrate into your practice setting. If you go to the next slide, you'll see if you're looking for screening tools, NIDA, National Institute on Drug Abuse, has a website with a huge range of screening tools there. You know, I was looking at what Steve was talking about earlier, and I realized, you know, one of the challenges is we keep on adding screens, right? We keep on adding things to fill out. And I'll talk a little bit more about that at the end, but ideally, what we really need is to move to a model where all of this is somehow or other integrated into a single, you know, that we can cover all the areas needed as effectively and as efficiently as possible without exhausting the patient or client. Next slide. So implementing screening, I really enjoyed hearing what Steve was saying about how they've integrated it there. A couple of different ways to do this. One is the patient completes it in the waiting room and later discusses it with the provider. In some cases, it makes sense for the provider to interview the patient. I've seen also using, if you can integrate it into web-based technology, like with an iPad or something, where a patient can quickly click down, that's really ideal. And if we could get all of our electronic medical records to speak the same language, it would be wonderful. Next slide. Again, that focus on brief intervention, this is great, not just for substance use, but for all the areas of health that we talk about. The training and motivational interviewing, solution-focused counseling, things like that will really help a provider to build rapport in just a matter of seconds, literally. That first minute of interaction makes a huge difference. I saw a study once that said the most important question was if a patient trusted their doctor. And if they trust, everything else flows from that. So how do we make sure that everybody's trained and not just looking at their laptop, but they're looking at the patient and making that connection? So the second is really providing respectful information and feedback. One of the things we do in Esprit is to always make sure to say, what is it that you like or appreciate or enjoy about using drugs or alcohol? Because everyone who's been in that situation already feels judged. And to have someone say, well, you know, how does it help you? What do you like about it? Even if they're in trouble, is important to understand their experience and then help you move towards motivation. And then the goal is to build readiness for change and actually negotiate a plan. You never want someone to leave without a concept of what they're going to do next. Even the smallest step that they can take between now and the next time you see them. Next slide. This is something we use in motivational interviewing, is the readiness ruler. I don't know how many folks have seen this, but it's a really neat little tool. You can just pull it out and hold it up and show patient or client, say, you know, in terms of, I hear you saying you like to change in terms of your level of motivation. Where are you on this? Is you not ready, unsure, ready? And if a person, for example, says a 6, our inclination is to say, well, what will get you to a 10? But actually, the smart way to use this is to say, okay, you're a 6. How come it's not a 5 or a 4? How did you get to a 6? So you're reframing it in a positive way. Next slide. There are lots of treatment options. You know, the ideal is what we call a warm handoff, and that is you have somebody down the hall. If you are a medical provider and you need someone in substance use, it'd be great to walk them down the hall. I have a colleague, Eric Brown, who's up in Caribou or Presque Isle, I believe, who he says their social workers leave 20 minutes of each hour unscheduled so that he can, if he's done a pre-screening, he can walk that person down the hall and say, here's someone you can talk to right now, because that greatly enhances outcomes. So there's counseling, there's medications. Self-help is obviously really big, and substance use, it doesn't work for everybody. It's important to remember that, but it does work for a lot of people. The other thing is that we know now of complementary treatments. Final thing I want to say is, final thing I want to say is whatever the innovation, as long as it's perceived as something that you're adding on into your practice, adding on top of, it will never succeed. The goal is really to transform practice so that these silos of health, mental health, dental health, substance use, nutrition, and environmental health are all a seamless part of a whole. And I think I enjoyed hearing your presentations before, because I think that's where we need to head, right? It's all health. And I think the final slide is just some other resources. If you don't know the providers in your area, you can call 211. Every state has that number. They can provide you with local resources, and there are these other government sites here. Okay, thank you. That's it.
Great. Thank you, Clay. Appreciate that. So we haven't gotten any questions yet, but I have some. And one is this question that you brought up, Clay, and I know we've talked about it as well here around the number of screening tools and how practices are and providers are starting to get a little bit overwhelmed at all the different screening tools. And I know, Steve, I've seen a matrix from you of screeners and ages at which they're screened. And I know since Maine Health Unification, you are working, at least on the pediatric side, of having a standard protocol of screening. And I was wondering if you would talk about that a little bit as to where we are at Maine Health.
Yeah, I mean, it's a legitimate issue. Some of it is the framing of it. And I think all three presentations focused on when providers feel that they have a way of supporting the patient when these come back positive, the acceptance in the practices is much higher. And also remembering that the majority of them are not positive, and you've now gotten information pretty rapidly when the patients, if they have at least a few minutes to fill them out prior to the visit. What we utilize as we're hopefully moving towards like using iPads is we have a laminated sheet with the questions on it, and we hand the dry erase marker, and then we just erase it and get it ready for the next patients that are all pre-visit prepped. The PSRs and the MAs know what's going to be handed out. We do try to balance how many we're doing at each age, and that's why that grid exists. There's no perfection to it, and there's you can alter it some. And then the final teaching I always do, if one of these major screeners comes up positive, so say the individual has a significant substance abuse issue, or they check off that someone hurt or frightened them, and I'm doing a well child visit, you can throw out the rest of the well child visit. Basically, you focus on what is the really major issue that we can have an immense impact on, that the patient now, for maybe the first time ever, has brought up. And so you could bring it back for the well child to accomplish some of the other things you need to accomplish, but you don't always have to do everything at every well child visit, except give immunizations. Always.
Right. Another topic that I wanted to ask all of you about is the positivity rates of some of these screeners. For instance, food insecurity, you saw that the positivity rate was like 8%. And it's the same here in the Oxford Hills area. But we know that food insecurity, in particular with children, and Good Shepherd provides this data, is closer to 25%. So I want to hear what you guys think about this. I have my own thoughts. Any comments on this?
Yeah, I can chime in. Yeah, I think that's a really great question, and it's something that, you know, we at Good Shepherd ask ourselves all the time when we're looking at our partners' data. I think there are a number of factors that affect the food insecurity rates, especially in clinical settings. One could be, you know, how the questions are being asked and who's asking them. The patient's comfort level with disclosing that type of information. We know specifically for pediatric offices, there's often a lot of concern that disclosing any type of information around food insecurity or housing insecurity or anything like that might trigger a call to Child Protective Services or something like that. And we know that, you know, stigma is still a really big issue in the state of Maine around food insecurity. So we do a lot of training at Good Shepherd around best practices for when you're screening patients, how to make folks really comfortable, how to engage in a conversation about food insecurity and nutrition, and how to kind of frame the conversation around accessing nutritious food and the importance of eating a well-rounded diet. And we found that makes folks a little more comfortable discussing issues as they come up. But.
Great. Anyone else?
Yeah,
Go ahead.
I was just going to add that I think stigma is definitely probably still one of the big reasons. I was thinking as you were asking the question of, you know, the comparison to when schools are putting out the paperwork for free and reduced lunches at the beginning of the year, and how typically they're not getting back the response that they would like or that they know is there. So even though the schools are getting maybe, you know, 50%, which is what they, you know, there's a certain line that they need to get in order to get the, you know, certain amount of funding, they can't get those numbers all the time. So they also see that in the early stages, like primary and elementary schools, they'll get higher numbers back. But as the kids get older, it's harder to get the forms back. It's, you know, something that kids don't either bring home, or that, you know, maybe the parents again don't want to say that it's an issue. So I think that, you know, people either don't want to answer the questions, or they don't really feel that they even qualify, or that, you know, goes back to Mainers are stubborn, and you know, sometimes maybe they just don't feel like they need it as bad as other people too. So I think there's still a lot of that going on. And then also just being in small communities, a lot of people know each other. So it just kind of goes back. They just don't want people to know, and they just don't want to say that they need that help.
Great, thanks. Steve, did you want to add something?
Yeah, I mean, all these screeners are point in time screeners. So always remembering, like, a lot of the bigger data might be from more in-depth surveys and those types of things, where here it's, okay, on this day, at this moment, I screened this family. Doesn't mean they might have not been food insecure a few months ago, or it might be, you know, in the future. And most screening tools, I mean, if we're averaging 5 to 10%, that's compared to a lot of what we do, relatively high still. It's definitely underestimating it. And, you know, I think the individual's family's definition of food insecure might be different sometimes than our public health definition, because I have families that I know, you know, work really, really hard to try to put food on the table, but, you know, they feel like they're succeeding and they'll mark never down. And 6 months earlier, it might have been, you know, some of the time. So, as I said, even though it might not be as high as we expected, I think it's just been incredibly successful. And if we get those, you know, we see it, and we can tell the practices that are in areas with higher poverty rates definitively have the higher rates. So we do know we're getting some accuracy on the screening. And yeah, no, it's been game changing.
Yeah, and I would add that, you know, even if the rate doesn't match the community, the trend probably does. And I think those trend lines are important.
And then
I would say, go ahead.
The other best thing, you know, is will a family come in, we'll do the screening, say they have diaper and food insecurity. You know, we give them the stuff in the clinic, we connect them to SNAP, they get connected to a food bank that sees them on a monthly basis. And then, you know, 6 months later, they come in and they check no on both of those questions. And it's just such a highlight for the staff, and the providers to kind of watch, that type of progress.
I just wanted to add in for screening for adults. I mean, most kids have to go to the doctor to be able to go to school. But the people that maybe you're screening, Clay, are adults who are actually seeking or accessing healthcare, where not everyone is. So that would also skew the numbers. Would you agree?
Yeah, that's right. And what we're dealing with is people who have come seeking assistance in one way or another.
Right.
Yeah, so you're not necessarily reaching the people who aren't there, clearly. I also want to say one thing I also like to emphasize, and I kind of referred to it when I talked about trust, but we have, I think, often a very linear model of practice that is assessment, diagnosis, treatment. And while that's true with certain physical ailments and things like that, the fact is that often assessment and intervention are co-occurring. So from the very first thing you say, the very first thing you do, the intervention has begun. And that can influence what is perceived as part of the assessment. So I read once Jerome Grubman said that physicians make their first diagnostic assessment in 17 seconds. And it occurred to me that our patients are making their first assessment of us in the same amount of time.
Yeah. Becca has a couple of questions. She's asking about the ethics of data sharing and patient communication. And I don't think we're talking at all about specific patient information that we are accessing. We're talking about rates in the patient population. But does anyone have a comment about the ethics of this?
Yeah, no, it's right. I mean, all of our presentations are de-identified population level data, but the electronic medical record and deciding, how much is completely secure, and trying to work on the, when do we use sensitive notes, and the confidentiality sharing is a daily challenge, in the practices. But at the same time, trying to balance that against the need to provide care, where if we put up so many barriers around confidentiality that I can't talk to the behavioral health clinician or share, between providers or different care teams, in the end, your outcomes are worse. And so it's something we definitively debate back and forth and try to thread the best, way forward. But it's an ongoing conversation.
And Clay, Becca asks you specifically about training health professional students and what the experience has been like with them and faculty experience.
I have to say, it started out as a big, kind of massive, complicated project, but it turned out to have its great rewards because all of our training was done in an interprofessional setting. So all the disciplines I described before, parts of their introduction was done uniprofessionally, but the advanced training was all in a shared group. So I have to tell you, as an educator in this day and age, and a lot of our stuff happened, it was co-curricular, so it happened on top of regular classes. So we would do a lot of this training in the evenings. And I have to say, to be there at 8 or 8:30 at night with 100 students in a big room, and not a single one is on their iPhone or iPad, and they're all talking, and no one's looking at the clock. It blew me away. And I think part of that was the discoveries they were making in training with one another and realizing how themes like this, like substance use, crosses the work that everyone is doing. So it was a very rewarding experience, and we got a lot of great feedback about it.
Thank you. And I guess a closing thought, and the reason I suggested this session in the first place was for people in community health and public health to realize that these screeners are taking place, and befriend someone in the quality department of your local hospital, and you can get access to some of this data. I learned that a few years ago, and now it's been very helpful with our work in the community, and just getting that window into our specific patient population can be very helpful. Well, I don't have any other questions. Thank you so much, everyone, for participating. I really appreciate it. Thanks, guys, for taking the time out of your day to do this. Really appreciate it.
Thank you.
Thank you.
Carl.
And take care.